Hello, everyone, and welcome to another episode of Dr. Gilbert Hosts. Today, we're going to be discussing the lesser known symptoms of Parkinson's disease. So, as you know, there are many motor and non-motor symptoms of Parkinson's. Non-motor symptoms refer to those that are symptoms that you can't see, but they are commonly associated with Parkinson's disease nonetheless. And these include depression, constipation, problems with blood pressure regulation. These are the common ones that most of you know about. But Parkinson's can also involve a range of lesser known non-motor symptoms, and these often receive less attention and they're not often talked about. So today, we're going to be discussing those symptoms that you're wondering, is this related to my Parkinson's or is it not related to my Parkinson's? And we'll be taking your questions about this very important and difficult topic. So we want to get those questions ready right now. But first, I'm going to be joined by a movement disorder expert who will help us navigate this extremely interesting topic. And that is Dr. Campbell Dewey. I'm going to introduce him to you, and then he's going to give a presentation, and then we'll rejoin with a Q&A. So Dr. Campbell Dewey received his medical degree and neurology training at University of Texas Southwestern Medical Center in Dallas. He then completed a movement disorders fellowship at the Mayo Clinic in Arizona, and he now serves on the faculty of the Mayo Clinic in Jacksonville, Florida, as a movement disorder specialist. He specializes in the diagnosis and treatment of Parkinson's disease and related disorders, as well as other movement disorders such as dystonia, myoclonus, ataxia, and other conditions. So I want to thank Dr. Dewey for joining us and sharing your expertise. Dr. Dewey, would you please do us the honors of giving your presentation, and then we'll rejoin for a Q&A afterwards. Dr. Dewey.
Perfect. Thank you so much for that very kind introduction. Of course, I'm grateful to be able to participate in this lecture series. I completely echo what Dr. Gilbert said. This is a very important topic, both for us to always review and have discussions with. And so I'm grateful that we get to have this dedicated time to dive into some of these lesser known symptoms that can be associated with Parkinson's disease. As an introduction, I know we are all familiar with what we would deem the motor symptoms, or the symptoms that are associated with movement that are with Parkinson's disease. So to kind of use the analogy of an iceberg, the top kind of right at the very beginning of Parkinson's disease, you have what is really required for a diagnosis, which is bradykinesia, what we call slowness of movement, rigidity or tightness, resting tremor, so a specific type of tremor, and then of course sometimes some gait changes and imbalance make up the four parts, the four motor symptoms that we are all familiar with as it pertains to the diagnosis, and often what we're looking at when we're managing Parkinson's disease. However, there are also a large number of non-motor symptoms. In fact, probably even more than are included in this list that are completely not included in these motor symptoms and are thought to be either related, tangentially related, and oftentimes confusing, both to patients, sometimes caregivers, sometimes to even physicians, as to whether or not it's directly related to Parkinson's disease and therefore how best to manage it. When it comes to the symptoms that we've got listed here, I do want to make a couple of caveats. We're going to break down a fair number of them highlighted in yellow here, but I made a note that when we talk about Parkinson's disease and the manifestation of symptoms, these are always in different sets, in different combinations, right? Every single patient with Parkinson's disease will have their own kind of flavor, so to speak. And so when we're going through this list of symptoms, I don't want you to think that these are guarantees or that you should have some of these problems necessarily, but just that these are some symptoms that might be present. And I want to kind of shed some light on the perspectives that we have in the medical community as it pertains to what they are about. So once again, just to kind of break it down, we're going to go through first some depression and anxiety, apathy, which is tangentially related, talking about some temperature, sensation controls, runny nose, drooling, and a few of these others listed here in just a moment. But one of the other things I want to mention is that for almost all of these non-motor symptoms, the first step is that we need to think about if it's even related to Parkinson's. And I'll talk a little bit about this as we move forward. And sometimes there needs to be some thought process put forward towards other causes before you immediately assume that is related to Parkinson's. So with that, I want to start with depression. This is probably one of the most common forms of non-motor symptoms that we can see in folks with Parkinson's disease. In fact, it affects up to 60% of patients with Parkinson's disease. Sometimes it's actually thought of as being almost a prodromal feature in certain forms of Parkinson's disease where it develops before some of the motor symptoms. Sometimes it's coincidence. Some people have had depression for many, many years or decades, and some of it develops after the diagnosis, sometimes related to just the diagnosis itself, and sometimes it's related to the manifestations and treatments of some of those symptoms. And these symptoms can be confused with many other integral parts of what happens in Parkinson's disease, things related to sleep difficulties, the fatigue that comes from different medications, and the energy levels that come with the fluctuations, apathy, which we'll get to in a moment, and also just bradykinesia, or slowness of movement, can often look like quote unquote depression, but it might not be. And of course, all of these are common in folks with Parkinson's disease. There's also a known link between depression and the impact it can have on some of the motor symptoms of Parkinson's. As mentioned, slowness of movement can sometimes be associated with depression as well as Parkinson's disease. And it can certainly have an impact on the cognitive effects of folks with Parkinson's disease. And importantly, depression is often treated effectively with actually the standard treatment that we use for someone without Parkinson's disease. So usually it's a combination of psychotherapy and or an addition of an antidepressant medication. The thought process is that while we think of dopamine as being the main neurotransmitter that's implemented in Parkinson's disease, there is often a mix of neurotransmitters that might actually be at fault to some extent, which is why sometimes some of these antidepressants that play off of the serotonergic pathways might also be useful for management of this particular symptom as well. Closely associated with depression is, of course, anxiety. This often coexists. Sometimes it's in isolation. And this is actually probably one of the most common concerns that I have with patients as we're managing their symptoms. Similar to depression, it can often be managed with basically standard anti-anxiety treatments, cognitive behavioral therapies, antidepressants, and there are a few specific anti-anxiety specific medications that are sometimes useful. But one of the things that I'm always very careful with when I'm thinking about anxiety as it pertains to Parkinson's patients is this related to the on-off states of medications as people wear on and off their levodopa, or is this unrelated? And of course, that takes a lot of nuance and pulling it out as we're talking with patients. But sometimes that's a very important distinction because one will have a different treatment than the other. Apathy is another one that is, in my mind, one of the hardest ones to manage because of how much it plays into the overall experience with what the patient is dealing with. Apathy, when we use that term, is really referring to reduced interest or motivation to perform activities. And while generally speaking, that could be in reference to not wanting to go to doctor's appointments or what have you, one of the most important issues is not wanting to exercise or stay active and losing the desire to remain mobile. And that obviously has a huge detriment in the long-term outcomes when it comes to Parkinson's disease, because that's a critical way that we fight against the ongoing decline that we can sometimes see. It also intersects often with depression. There's often comorbid interactions between these two. And of course, the cognitive decline that comes with all of this can sometimes be accentuated through apathy as well. Ultimately, apart from just the encouragement to work through things like mental, social, and physical activities, there are a few medications that will sometimes be considered. Certain things such as methylphenidate or even dopaminergic agonists can sometimes improve apathy, and actually rivastigmine, which is another type of medication, can sometimes be helpful as well. But to be honest, this is often a challenging thing to truly treat, and is often one of the things that gives me the most grief as we're trying to engage with some of these symptoms. Visual problems. This is probably where we start deviating away from what maybe we are more familiar with when it comes to some of these non-motor symptoms and getting into some things that maybe some of you thought, wait, I didn't know this might be related to my Parkinson's. So visual problems is actually a relatively common problem. I've included a paper from 2020 that was published that just outlines a whole list of really kind of eye-related concerns that patients with Parkinson's disease might report. And you can see that, compared to healthy controls, there's a pretty sizable number of concerns that patients will mention. Things related to blurry vision, watery eyes, trouble with quick movements, like they can't follow it with their eyes, colors sometimes looking differently than how they would have, and then not directly related to the vision sometimes, but even sometimes seeing things that are not there, like hallucinations. All of these, and certainly the more mild spectrum of this, can be seen quite commonly in folks with Parkinson's disease. And of course, there's a lot of complexity with just as we age, there's changes that occur with vision. But a lot of this stems, I believe, with things related to kind of two issues, right? So on one, there can be some eye movement changes where it's harder to focus or to kind of keep up with speed with objects. But the other thing is with folks with Parkinson's disease, often one of the kind of telltale signs is reduced facial expressions, what we call hypomimia. And with that is a reduced blink rate. It's kind of one of the ways we providers will sometimes gauge some of that manifestation. And of course, why do we blink? We blink to kind of provide lubrication, to get dirtiness out of our eyes. And if you're not blinking as much, that can lead to dry eyes, eye pain, and other types of maybe irritants that might have an effect as well on some of these things. And as mentioned, sometimes the color palette that one might have had previously might be changing a little bit as time goes on associated with disease. Ultimately, this is a challenging thing to completely get resolved, although frankly, with the help of our ophthalmology teams, usually things like either prisms or other types of strategies to help navigate some of these symptoms are often recommended for folks as we're navigating through these problems. Pain is a very common problem that is oftentimes thought of as not being related to Parkinson's disease. And to be fair, a lot of the times it might not be, as I'll get to in a second. But pain in Parkinson's disease, the way it is associated, often is related, in my experience, to rigidity or stiffness. So that is one of the cardinal motor features that we've talked about at the beginning. And while we always think of it as just, oh, it's tight, what does that tightness lead to? Depending on how tight and depending on what you're trying to do with your arms or your legs or even your trunk, it might lead to exacerbated pain as you're trying to fight through that. Certainly, even exercises or working with therapists might sometimes lead to exacerbation of pain. For some of our patients, they will get dystonic cramping or tightness. And I can go into that more maybe during a question and answer time if we have time. That will certainly cause pain. There's other types of pain that is related to more just of a sensation perspective as it pertains to kind of what's called a central pain as it relates to how the thalamic signals are receiving some of these pain signals from the rest of the body. And then, as mentioned previously, the on-off transition state when folks are going from these wearing off states or maybe when they're dyskinetic, there can often be an association of uptick in pain, similar to the fact that I think some of the rigidity is coming back, but that can also sometimes be a telltale sign that we might be not having the most effective management of the medication. However, as I mentioned, pain is horribly common in general. And so there's a lot of other things that are often age related that need to also be in the back of our minds. Things like arthritis, radicular pain, or the compression of the nerve roots that are often common as we get older. And then, of course, neuropathic pain is just a common problem across many patients. These are all things that we will see as well. And it's important to parse out the differences when you're trying to think about management. Abdominal discomfort. So GI, I guess keeping it broad, GI related symptoms, which will go into a couple specific manifestations, are a very common problem, mostly because it's impacted both by Parkinson's disease itself, as well as actually the medications used to treat Parkinson's disease. And this can manifest kind of in many different places, both with impairment of the food kind of going through the stomach and intestines, leading to bloating, sometimes nausea, sometimes GERD. Sometimes it just manifests with poor appetite or what we call kind of early satiety, where you just get more, you're full faster. Abdominal pain. And then, of course, the mobility issue then can downstream lead to things with constipation. Uh, Similar problems almost across the board can also occur when it comes to levodopa. Some of our other medications can also drive some of these symptoms. And this is a very common problem and worth discussing in more detail. So when it comes to that gastric motility, or really the movement of food, from one part of the digestive tract to the next, is challenging. And certainly there's some simple strategies that are often recommended when it comes to, what could you work on tomorrow, for example, to see about improving this. Sometimes some lifestyle changes are actually all it takes to see improvement. Things such as eating small but frequent meals, drinking fluids during meals, which some of us do, some of us do not. Certain types of foods, like fat in particular, can sometimes make this more challenging. We'll come back to talking about fiber in a second, how that can actually help a little bit with at least the downstream effects. And then actually one of my favorites that I think is actually a very simple and elegant solution is actually just walking. Taking a walk after eating, that hits a couple of good things, right? Exercise and mobility is always encouraged, but this in particular is useful for the gastric motility as well. Rarely there might be some prescription medications that could be used, but again, sometimes that is not always the greatest option because they sometimes come with other side effects that might also ironically create some GI issues as well. Constipation, which is probably one of the most common GI manifestations related to Parkinson's disease, is a common problem and one that I am very familiar with having to discuss and encourage with patients. One of the most easy and probably beneficial across the board options for management of constipation is being consistent with both meal times and, generally speaking, maybe the meal like quality, quantity, that type of thing. I feel like sometimes patients that take huge amounts or intermittently fast or change significantly what they're intaking might lead to some complexity here. This also plays another boon of when you're taking your levodopa. That's another thing that kind of has to be timed special when it comes to protein. So being consistent across the board can make things help them be more regular. As mentioned, fiber is a simple initial step when it comes to management of constipation. There's a whole list outlined here that you could consider adding kind of to your taste, I should say. Some people just like prune juice or will try prune juice. Other people will have some specific things that they'll try or added to each meal, depending on how they like it. Certain foods also, certainly probiotic like yogurts can be useful as well. But ultimately, probably the most important reason constipation develops tends to be the amount of fluid intake not being sufficient. So I always argue increasing fluid is most important, increasing exercise and movement, as mentioned. This helps for many, many different reasons, not just the constipation, but it's certainly something worth keeping in mind. And then, of course, there are always medications that can cause constipation, pain meds in particular. While required for certain types of, post-op surgeries and things of that nature, these can also exacerbate constipation. And certainly even some of our medications used for Parkinson's disease can cause constipation. So it's always important to circle back, reassess, make sure the medications that you're currently taking are the ones that you need to be taking for this moment, and go from there. For medications, we've listed a few. Again, this is probably a much longer list than we have listed here. I'll mention a couple that I like to use. Some of these are actually even over-the-counter medications: Cilium, Docusate, Senecot or Sena, polyethylene glycol. Lactulose is a little bit more of the next level, so to speak. And some of these other medications that they all kind of play off of different elements. So for most of my patients, probably around 90% of them, I mean, usually one would be sufficient, maybe two. But for folks where it's really, really a challenge, or we're struggling for maybe a secondary reason, some baseline GI issues, sometimes it's worth combining some of these medications to kind of create a general holistic approach. But of course, the challenge is not pushing yourself too far and ending up into the looseness of stools. So it's a little bit of a balancing act. One of the things that I find quite useful is actually just being consistent, right? If there's one of these over the counters that you can take regularly that is useful and kind of just keeps you from becoming constipated, this tends to be a pretty good strategy overall. Drooling, medical term is sialorrhea, that you will see, is a problem that manifests through two main reasons. Part of it has to do with the autonomic system that we're going to talk about with actually the next couple of these secondary or non-motor symptoms. But it also has a lot to do, going back to when I talked about the eye blinks being reduced. Sometimes there's what's called reduced facial expressions in the lower face, where there's a little bit of kind of the mouth being held open, or reduced ability to kind of bring the mouth in to close. Sometimes there might be some swallowing challenges, but that's not a horribly common symptom early on in some folks with Parkinson's. Um, Ultimately, the solution for this is a tiered approach, usually starting with either, again, lifestyle modifications, like something to kind of remind patients to swallow consistently. Something like a hard candy will sometimes be used in my approach, but sometimes things like medications. There's a few medication classes that are useful for this. And then for folks where really nothing's working, a relatively safe treatment is actually botulinum toxin injections, funny enough, targeting some of the salivary glands. This works very, very well. But of course, what you're left with, it's a 3-month cycle each time. So just something to keep in mind when you're going down this process. In a similar vein, runny nose, what we call rhinorrhea, is quite common. This is one of those that I learned about kind of out of fellowship as something that I never would have thought associated with Parkinson's disease. But if you look it up, I included a paper here that I remember reviewing with one of my colleagues. It's actually quite common, right? Up to 40-45% of patients might have just persistent runny nose or intermittent runny nose. And, as symptoms go, it's usually easy enough to blot it away, but it can be quite bothersome to patients to the point where it even is brought up in clinic as a concern that people are having. Sometimes some nasal sprays can be used to decent effect, but ultimately this is one that you need to be very careful. You're checking for other things as well. Allergies or colds are also common reasons that people might have some rhinorrhea. Poor temperature, poor temperature control is another issue that can sometimes happen in folks with Parkinson's disease. As mentioned before, there's an autonomic nervous system influx interaction that can lead to really a manifestation quite diverse, but in this particular symptom can be related to body temperature control. Usually it's cold intolerance is what I tend to see, where it's just having to bundle up. It's hard. You can see here, we think it's related to overconstriction of blood vessels. But some patients might have it the other way around, where you have heat intolerance, excessive sweating, again, kind of keeping with just a lot of things that are just excessive because of this autonomic nervous system dysfunction. Ultimately, the solution is kind of dealing with it as you'd expect, right? So if it's the cold intolerance, working on things like dressing in layers, helping to conserve that heat. One of the things that I personally use, though I think have cold intolerance, will be hand warmers. Those can sometimes be useful in cold areas. Hot beverages, of course, can sometimes be useful. And then for when you have excessive sweating, apart from kind of doing the opposite of all those things, trying to stay cool, there's also the importance of going back to what we talked about, which is maintaining hydration, because that's a key feature for multiple different things. There are certain types of, kind of escalations that you can push this excessive sweating all the way up to oral medications or even botulinum toxin injections again. But this is a pretty uncommon manifestation, needing to go all the way to this level. But again, it's certainly something where if you feel this is something you struggle with, you can always think about this being something that needs to be evaluated. Sexual dysfunction, in keeping with the autonomic themed problems that come in Parkinson's disease. This is obviously one that is sometimes hard for patients to bring up, or maybe you associate it with just we're getting older. And to be honest, there is an element that might be happening, but when it comes to Parkinson's disease specifically, there's actually a fair number of reasons where we can see this happen. So obviously, playing off of what we originally talked about with depression and apathy, there can also often just be a decrease in sex drive. Rarely there might be actually hypersexuality, which actually I sometimes wonder could be related to a side effect of medications if that's happening. Impaired motor function, right? It might just be more challenging to engage in sexual activity because of some of the motor symptoms. The fatigue and depression we talked about, but sometimes the erectile dysfunction is actually related more so to the blood flow autonomic dysfunction that we've talked about related to a fair number of these symptoms. Ultimately, again, as with most of what we've talked about, there are certainly medications that could be considered. There's other ways of kind of manipulating circumstances to see that ways that might be able to re-engage some of this element. But once again, because there's so many ways that this can manifest as we're aging, it's worth double checking with your physician if there's anything else that needs to be checked as you're going through this process. I'm almost finished. I apologize. When it comes to weight loss, this is a very important one. It is encouragingly not a common one early on, but it is still something that has really multiple prongs that bring it to the head. For example, as we talked about, there's decreased appetite for many different reasons, whether it's apathy, depression, side effects of medication with nausea, some of that GI symptoms we talked about. You could have the opposite problem where you actually have increased energy expenditure, where you're moving too much. I guess it's not the opposite problem, it's just another problem. Particularly with dyskinesias is the one that I tend to see it, where you're just excessively moving, you're burning calories. So you're both not taking in enough and you're also burning. And then you have some of these other symptoms we talked about: difficulty swallowing, slow transit, mobility issues where it's hard to actually even get some of that food, or maybe it's harder for you to navigate food into the mouth. And then, of course, I know some patients, they tend to have issues balancing levodopa and food. So they will often say, well, I need my levodopa. I'm going to forego trying to take med or food as much as I could. And that's obviously, there's ways around that, but these all kind of combined create a bit of an issue when it comes to weight loss. Obviously, weight loss can be both a marker and a contributor of advancing disease. It can mean that there's something more sinister going on, and it can also be something that we need to really address because it can lead to downstream additional problems with easier fractures, malnutrition, vitamin deficiencies, many things that can ultimately lead to significant worsening of this disease, and really needs to be addressed from the get-go when this is something that is brought up. It is important from the patient and caregiver's perspective to mention this to their providers if they're concerned about it, right? Sometimes it's something that's not mentioned if it doesn't come up. So it's always important to please make sure that we go through that with your provider if this is a concern. Ultimately, you have to go through a pretty standardized approach when it comes to weight loss, including many different additional workups that might need to be considered. But ultimately, you need to address it as quickly as possible to avoid wasting and losing muscle mass, because that will have a deleterious effect on your ability to exercise and maintain function. So I blazed through a lot of symptoms. I apologize if I didn't go through some of them as deeply as I could. And I will remind you that I actually didn't cover any of these. So the yellow are highlighted here are some very important ones that were not covered in today's lecture. But certainly if some of them come up on the questions, I'd be happy to discuss a little bit as well. So with that, I know I went a little bit over what I promised. Here's kind of my ending slide. And Dr. Gilbert, I'm ready and welcome to take any additional questions.
Fantastic. Well, thank you so much for that information. And we have lots of questions for you already. I really
Good.
don't know where to begin. So I think we're going to begin with the last one asked, which is low blood pressure. So this
Mm.
is one of the not rare side effects. It's relatively common onward symptom, but it's something that people really have a hard time with. Could you talk a little bit about the problem of low blood pressure and what to do if your doctor has tried a whole bunch of things and you're still having trouble? you know take us starting that topic for us.
Yeah. I mean, it's a great question. Honestly, this is a topic in and of itself. There's so many nuances to really what we're talking about when we talk about blood pressure is, the medical term hypotension will get mentioned. Most cases in Parkinson's disease, the more specific term would be orthostatic hypotension. Orthostatic meaning feeling lightheaded or your blood pressure drops when you go from a lying to a sitting or sitting to a standing position. Often it manifests when patients, stand up real quickly. You're about to start walking, but you feel real woozy. That's a kind of a classic manifestation of it. Very, very common in patients with Parkinson's disease. Very quickly, it comes from two main reasons. Reason number one, again, I know I'm saying this over and over again, but it comes to the autonomic dysfunction that comes in Parkinson's disease related to some extent, in many cases, the alpha-synuclein misfolded protein having an effect both in the central and peripheral nerves, having a kind of a breakdown in how that autonomic system is working. And of course, the fine nuance of how we maintain blood pressure and heart rate is a very well-oiled machine when it works correctly. So any type of disruption will make it so that it's really hard for us to navigate the blood pressure management. And then the second one is actually for almost all of my dopaminergic medications, particularly levodopa and some of my dopamine agonists, a known side effect is lowering blood pressure. So it's a challenge because both treating you and by having Parkinson's, there's also this effect that can be happening. Oftentimes, there's some issues with other medications as well, like high blood pressure that people will be on that can be something that need to navigate. But ultimately, it's much like all of these, it requires going through a systematic approach. In my mind, the first way of managing orthostatic hypertension is first reviewing medications to see which medications you need to be on and which medications you've been on for like 15 years and nobody ever thought to stop it. Sometimes some of these medications can lower blood pressure, whether they know it or not. Secondly, there's a whole list of what we kind of call orthostatic hypertension recommendations, which are just kind of lifestyle modifications that, while they're not necessarily all fun and games, they really do work and are a very easy first line solution. Things like when you stand up, don't immediately start walking. Pump your legs a little bit before you get out of bed. Drinking lots of water. I highlight that all the time. And sometimes increasing salt if there's not an issue with that from a cardiologic perspective to kind of, again, bulk a lot of fluids into your body. But for a lot of folks, for a number of folks, that's not sufficient. So then there are medication classes that are designed to push the blood pressure up that it gets tricky because a lot of that will then push the blood pressure maybe too high up. So it's a tightrope that is walked very carefully. I think I saw another question that mentioned what happens if it's too high. That is the conundrum that we run into. In fact, there are some times where we will be dosing a medication to increase the blood pressure in the morning and then giving a medication to lower your blood pressure at night, because when you lie down, your blood pressure goes up. To be honest, there is usually not a perfect solution because the best solution is having an autonomic system that works well. I think one of the most humbling components of what we do is realizing how much the autonomic system works well when it's there, and how much of a challenge it is navigating when it is not working well. But again, it's a triaged approach, and there's actually a fair number of medication classes that could be always tried. But ultimately, within these combination of effects, there's ways to at least help out with that symptom. Sorry, I went long on that one because that's an
No, that's
important topic.
fantastic. And another thing to mention, specifically in the summer, I'm looking at the 86 degrees outside where I am. It's particularly a problem where people can be exacerbated by dehydration. So, keeping the
Absolutely.
hydration up and also adding salts to your diet can keep that fluid retained in your blood vessels. So certainly a message for the summer to reiterate. So thank you very much
Yes,
for that question.
absolutely.
Our caller has learned something to help them. Thank you for that. The next big topic that I want to bundle together is urination,
Hmm.
another topic to mention. So could you talk about urinary urgency and leakage, and what you would do to inform that patient?
Yeah. So, urinary disturbances, I'll keep it vague for right now, are a less common than the orthostatic hypotension, but it is certainly a common problem in a fair number of patients. Much like most of these symptoms, again, there's often reasons for this to be developing as we age and as medical conditions accrue. I think of patients that have had surgical reasons for benign prostatic hyperplasia, for example, where some of this can be certainly related more to those issues, but there are a number of patients that will have truly related issues as it pertains to urinary dysfunction. And to be honest, much as I've said before, the autonomic function plays a role in both how we urinate and how often we urinate and kind of what it how successful, I guess maybe I can put it, that urination is. Um, Often probably the first signs is increased urination frequency, particularly overnight can be an issue for folks, and ironically this plays right off of what we just talked about, increased fluids, right? So we're putting in a lot of fluids, so sometimes it's got to come right back out. But it is certainly a known problem that can occur in patients. In my experience, for a lot of patients where this is a prominent feature, I often rely on an initial evaluation with a urologist to think about other reasons that folks might be having urinary insufficiency or incontinence sometimes in extreme measures, because oftentimes there might be some simple solutions that are, I guess, maybe tangentially related to what I see in Parkinson's disease. But ultimately, there are a handful of medications that could be tried that just kind of overall helps reduce I guess, the frequency and the demand that might be going on when it comes to some of these urinary symptoms. But ultimately, lifestyle modifications tend to be an initial first step, as it is for most of these autonomic dysfunction issues. But it is a common problem and one that needs to be adequately addressed, not just kind of thrown under the curtains and said, "Oh, maybe you just got a UTI." That's easily checked and easily fixed. And if that were the case, you wouldn't be dealing with these problems consistently. So I think it's always important to have that in the background as something that, if it's certainly a concern, a symptomatic bother, then it's worth bringing up to your providers for further clarifying either workup and or potentially management.
Yeah, I'm glad that you mentioned that duality that we have to deal with all the time, where we're pushing fluids because of blood pressure, etc. And that, of course, makes people have to urinate a lot, and so they don't want to increase their fluids. And I really get that. It can affect your lifestyle and your ability to go out, etc., if you constantly need to know where the bathroom is. But that tension is really just along the lines of what you're saying. It's all a balance. You definitely need those fluids, even though it's going to push you to have to go to the bathroom more. And that's just another challenge of Parkinson's disease and and other disorders of aging as well. So just something to
Absolutely.
keep in mind. That's really important. There was a question a little bit earlier about recurrent UTIs. You mentioned
Hmm. Hmm.
that sometimes you feel like you need to go to the bathroom and it turns out to be a urinary tract infection. Sometimes there are certain people who get a lot of UTIs. How is that related to Parkinson's? And should a person be taking a prophylactic antibiotic to prevent the UTI? So that may be a
Yeah.
little out of our wheelhouse, but perhaps
Yeah,
it's
it's a great question, and it's showing next level thought. I love it. So, piggybacking right off of what I just said, urinary tract infections in and of themselves are not directly related to Parkinson's disease. I do not view Parkinson's disease as necessarily um, an immunosuppressive state, for example, where you're at risk of other types of infections. But the manifestations of Parkinson's disease can lend itself towards maybe recurrent UTIs via the things we just talked about, right? If you're having to go to the bathroom 5 times a night, that increases the risk of there being potentially a bacterial exposure. And of course, depending on how frequently you're urinating, you might not recognize that you're now having new signs of a UTI. So sometimes things might manifest a little bit later on than otherwise, because maybe it's chalked up to, oh, you just got Parkinson's, no need to check anything, right? Almost the opposite of what I was talking about earlier. um I think that generally speaking, prophylactic management of any type of bacterial infection tends to be frowned upon, simply because you're actually more often than not setting yourself up for still getting a UTI, but a bacteria that's resistant to other types of antibiotics if you're not careful. I would certainly say that if there's a specific circumstance where that's recommended by your provider, and maybe there's been a discussion with either infectious diseases or someone who specializes in urinary tract infections, or I know sometimes folks will have like indwelling catheters or like very obvious reasons for maybe an increased risk of infection. Outside of that, I'd be very cautious about repeatedly exposing yourself to antibiotics, because you're just kind of potentially rolling the dice of this becoming a more challenging bacterial infection if it does develop resistance. I'm being vague here because, again, I'm not in infectious diseases, but that's my general understanding when it comes to that component.
Thank you. There are a bunch of questions that refer back to your comments about runny nose. We'll try to deal with
Hmm.
a bunch of them. Is there a specific nasal spray that has been recommended? And why does it not seem that ENTs are aware that runny nose can be a Parkinson's symptom? So maybe answer those and
Yeah, it's a great questions. So I'll answer the first one first. There's not necessarily a specific nasal spray that I found that it's been recommended. I know things just the over-the-counter sprays, kind of the decongestant nasal sprays, Flonase and things of that nature, tend to be an initial first spot to start. I would be cautious necessarily with just starting it yourself. Maybe talk because there's are some of these that, depending on, I guess, the frequency in which it's used, it can actually kind of create you having more runny noses. So you have to be a little cautious with that. But the issue is that this is not very well studied, generally speaking, in patients with Parkinson's. And so there's challenges with knowing, exactly what the data suggests. To the point of the ear, nose, and throat team, to give them the benefit of the doubt, almost for sure what is happening is they are being asked to comment about why or if there's a reason for runny nose that is within the realm of an ear, nose, and throat disorder, such as sinusitis, or some sort of nasal septal problem. Could there be some sort of like ear problem with these types of situations? And from their perspective, it's kind of a binary yes no, right? You either have evidence of sinus disease or you do not have evidence of sinus disease. I think that this is also just the fact that we just need to be better as a community and being aware of what all these non-motor symptoms are and what they include, because this is something that even me in advanced levels of my training was not familiar with as being a common symptom, but it absolutely is. I'm sure the vast majority of patients that are sitting here might be thinking, man, is that what's happening? So I think it's we got to check to make sure it's not something else, as we've talked about. But ultimately, my hope is with actually, frankly, these types of events, this can become a bit more of an educational sphere for folks even outside of the movement disorders world to become engaged with and understand, as we're thinking through how we manage the whole patient with Parkinson's disease.
That is a great segue to a question that I would like to answer because I was just asked this, so I looked it up. And that,
Perfect.
am I interested in finding out? I'm interested in finding out if burning mouth syndrome is associated with Parkinson's disease. So this is a perfect example of what Dr. Dewey was saying before. Burning mouth syndrome. That's interesting. We actually look up in literature, and yes, there is a literature on the association of this relatively rare condition called burning mouth syndrome, where you feel like your mouth is burning, and Parkinson's disease. And the literature goes back all the way into the late 90s, but it wasn't something that really I knew much about until I was asked this question. And so, again, one of the themes that have been coming out of this session is you always have to look for other causes. So if you do have a burning mouth sensation, you definitely don't want to be like, oh, this must be Parkinson's. You want to make sure it's not a vitamin deficiency, that it's not diabetes, etc. So you do want to have that workup, make sure your vitamin levels are good, make sure you're not having any manifestations of diabetes, etc. And then with everything normal, it can in fact be blamed. It is a little bit of have an increased frequency among people with Parkinson's. How can it be treated? So again, it's rare enough that we don't have the one go-to medicine that for sure helps everyone, but there is a literature on maybe a medication like Neurontin or gabapentin may help in some people. There are other prescription medications that have been suggested. And so bottom line, if you have a symptom that you're not sure of, the process is go to your primary care doctor, make sure it's not something else, then consider that maybe it's part of Parkinson's, and then consider what may potentially help it. So that's sort of the trajectory for all these. So thank you for that question. That was one of the first ones that were asked. So let's move on. We have many, many more questions. This is a great one. Somebody's mentioning hammertoes.
Mm-hmm.
Does hammertoes have anything to do with Parkinson's? And if so, what do you do about it?
Yeah, it's a great question because I actually run into this discussion myself when I'm seeing patients, because hammertoes is, I think, from the medical side, thought of as being an orthopedic problem usually. So it's related to the tendons being tight and kind of becoming almost stuck into a position where it can kind of be curled and cramped upward. Usually it's the proximal, the near part of the toe is being bent upward, and then the distal or the later part of the toe may be curling down. Uh, I think outside of Parkinson's disease, nobody usually bats an eye about hammer toes and says, "You got hammer toes. Let's talk about maybe some splints or some braces, or if it's really bad, maybe we need to talk about surgery." But in Parkinson's disease, there's actually a little bit of some overlap where I actually do need to pause and reevaluate, because sometimes what people are told are hammer toes are actually what I mentioned, I think, in one of my slides as being a dystonia, okay, or a toe curling dystonia specifically, which in my mind has some differences, right? Hammer toes tend to be kind of almost a permanent fixture once they're there. Maybe it'll change a little bit depending on how much effort you're putting to kind of flex or extend your toes, but generally speaking, it's kind of there, as opposed to dystonia, which, at least if you're not on levodopa, can be a bit of a fixed problem or a persistent problem where it's cramping and kind of curling those toes downward. But when you're on levodopa, it creates this weird dichotomy of almost a fluctuation, particularly if you wear off, particularly if you wear off overnight, where I hear a lot of patients say, oh, well, I wake up in the middle of the night with my toes curling. Right. I don't think, oh man, they probably got some hammer toes. I think this is dystonia. I think they're wearing off with their levodopa. And I start talking about ways to help dose some medications overnight to kind of help prevent that wearing off. So when if it clinically, objectively looks like it's hammer toes and there's no kind of fluctuation of symptoms, I usually get my orthopedics to weigh in about whether or not, is it just hammer toes, and do we just need to do like a tendon release or something like that? But if there's anything else, or if there's not that, or if there's any type of fluctuation, especially related to the levodopa, I tend to take ownership and say, well, let me just pretend it's a dystonia for a little bit, work it through, maybe even try some Botox, depending on how things are going, before I turn around and send you off for like a hammer toe surgery. Does that make sense?
Yeah, that would be exactly what I would answer too, because sometimes we have these names for things and we're not always consistent on what the different specialties are calling things. So we find that like frozen shoulder, you'll get something
Mm-hmm.
referred for frozen shoulder and it's not really their shoulder. It was just a mixed message from the brain, which is actually Parkinson's. So we have this
Absolutely.
neurology tension sometimes, and hammertoes is another great one example of that. There's a great question here about insomnia.
Mm.
Insomnia a symptom of Parkinson's? What treatments do you recommend for that? And is magnesium a good solution? Those are our sleep questions.
Yeah. So that's one of these yellow, not covered in today's lecture, because yet again, this one would go for another probably 45 minutes minimum. So very briefly, sleep-related disorders in Parkinson's disease are quite diverse, and they range from, I think if you were to Google it, probably the number one thing that comes up associated with Parkinson's disease is what's called REM sleep behavior disorders, or acting out of dreams, dream enactments, those types of things. But by nature of that term, that usually occurs later on in the night. And actually, it usually doesn't wake the patient up. It might wake the bed partner up, and then they might wake the patient up. But sometimes this is something that they're dreaming away and they don't realize that their movements are occurring. uh, Still something worth treating and evaluating, but it's also different. That's not the same thing as insomnia. When I think of insomnia, there's two main types. There's falling asleep insomnia, where you can't get to sleep, and then there's staying asleep insomnia, where you're waking up frequently. Probably one of the most common causes of, I guess, the waking up in the middle of the night syndrome is things we talked about: urinating through the night and having to get up over and over again to go to the bathroom because of the fluids you're taking in, and the dysautonomia. Or it's related to the wearing off of the medications, and sometimes actually, and I'll come back to this, insomnia might be related to the levodopa amount. Uh, Versus the falling asleep insomnia. There's many issues that can be driving that. I mean, some people just have chronic insomnia for many different reasons. Ultimately, when I'm seeing someone for and they mention insomnia as a chief issue, there's two main things that I take ownership that I really want to make sure is not something that's going on, and then we need to figure out the rest of it. So step one, if they're on levodopa, is when are they taking their levodopa, and do I think it's contributed? So sometimes when they take a fast acting levodopa right before bedtime, I find that it kind of might paradoxically jazz some patients up because you're like ready to get moving. So sometimes that might have an impact on falling asleep. Versus if you don't take anything overnight, or you don't have a long acting version overnight, you might wake up with kind of the wearing off. So those are kind of how my levodopa could sometimes have an impact. But to be honest, one of the biggest issues, and this is the second thing that I always recommend usually, is there's a lot of other reasons people have trouble sleeping, and not the least of which is obstructive sleep apnea. So obstructive sleep apnea is commonly indicated or implicated in patients with Parkinson's disease. I forget the specific percentage, but it's a non-insignificant number of patients might have some comorbid OSA. And in those cases, the management's simple. We need to figure out how bad it is, and if you need to be using some sort of breathing device through the night. And to be honest, if that's the issue, it doesn't matter what medication I pass your way, it's not going to be restful. Ultimately, there are medications that are useful for insomnia. Most of them you need to be very careful with because of either risk of addiction or, frankly, it's not really helping the insomnia piece. It's just knocking you out, kind of giving you almost a medication-induced sleep, which is not necessarily the same as what you're really striving for. So there's a lot of nuance to this one. Usually, before I start prescribing meds, I have to do a little bit more of a diagnostic workup before we can be confident. But there are definitely some challenges, and this is in particularly a big issue with a fair number of patients because of how common it is.
Great. And we have another really common topic that we should talk about, which is skin problems.
Hmm.
Any relationship between rashes, scalp issues, um,
Yeah.
and
So,
yeah.
oh, sorry. What was the last part there?
No. What is what is the relationship between skin abnormalities and Parkinson's? Fairly.
Yeah. So this one's a challenging one because first of all, I don't like dermatology generally speaking. I like neurology, but there is a weird correlation between sometimes the skin manifestations and Parkinson's disease. I know kind of in my prep for this talk, I was reading up about how there can be some certain types of kind of skin rashes, usually kind of like redness in the face, those types of things that can occur, which has some specific medical terms, but it's usually not something that is horribly concerning or emblematic of an underlying, skin related process. Whereas conversely, there is a historic concern that Parkinson's disease has a higher risk of certain types of skin cancers associated, particularly things like melanoma, actually. So sometimes patients, especially those that are at risk, whether they had just long exposures in the sun or throughout their life or whatever it might be, where it's often recommended to at least have some dermatologic evaluations where you just kind of do a top to bottom skin check to look to see if there's anything concerning, because sometimes those can be uh, implicated as well as associated with it. And I want to mention one quick thing before I move off of this topic, and that is maybe why there can be some skin related changes. I know it's hard to understand how that's possible, and I'll be honest, I'm not sure if I've really read into this too much, but I actually know that one of the diagnostic tests that we use these days when it comes to making a diagnosis of Parkinson's disease has to do with alpha synuclein. And what we have found is that we actually, rather than having to go all the way into the spinal fluid, we can actually find that misfolded protein in skin. And so actually nowadays there's ways of checking through skin biopsies whether or not there's some alpha synuclein deposition there. And I only wonder if that might be part of where some of these things might be developing. But I'll be honest, that's just me thinking out loud as we uh, put these two relatively, you'd think, almost unrelated things together, but there is a little bit of an underpinning process between these two situations.
Yeah, that's a really good point. I mean, I think it just highlights that Parkinson's disease is not just a disease of the brain; it's a
Hmm.
disease of nerves, which are all over the body. And so, yeah, you can see Parkinson's abnormalities in nerves in the skin, and you can have skin manifestations, as you mentioned. What I was reading, I had got a question in my Ask the Doctor just the other day about
Hmm.
somebody who felt that there was this oily substance all over their skin, and in fact, you can have autonomic dysfunction of the sebaceous glands, which are glands in the skin that overproduce these oils and can cause rashes and all that. So back to our topic here, which is that yes, problems that you don't think are related to Parkinson's could be related, but you always need
Hmm.
to do that assessment first to make sure it's not anything else. Back to our same old messages. We have a lot more questions, and we're really nearing
I
the
know
end of
that they're coming in faster than we can answer them.
no, they're coming definitely faster than you can answer. But I like this one, and I want to read this. So this is somebody who says, recently my husband has had episodes of suddenly falling asleep. We're unable to wake him. They can last a few minutes to multiple hours. Then he'll wake up. During the longer sessions of unconsciousness, he'll have movements, talking, and doesn't seem to be particularly coherent. What is this? Is it related to Parkinson's? This is a tough one.
Yeah, it's a tough one because I don't want it because it's specific for a patient. I want to make sure I'm not making a diagnosis via virtual situation here. But I'll be honest, these types of kind of neurologic fluctuations can be seen in folks with Parkinson's disease or even just Parkinsonism. And I mention that term specifically for a reason in a second. Knowing nothing specifically about this relative, I think that the first thing I would wonder about would be medications, right? Usually, medication changes are a very common issue for why people might be having symptoms early on, and what ends up happening is when that happens, we need to um, reassess and reevaluate and say, well, where are we as it pertains to these symptoms with relation to the medication? I will also make one quick mention, which is not the purpose of this talk, but there are also other forms of Parkinsonism that can actually manifest with really cognitive fluctuations, right? So I'm thinking more of some of the ones that are related to more of the dementia-like category, where sometimes there can be just lack of, just kind of, nothing there for a period of time that can sometimes be associated with a different type of syndrome than what we were talking about here today. But I'll be honest, I would say that the first step is always reassess the meds, reassess the overall physical health. There can be a lot of reasons you can have some of these things, so you just need to make sure that you think through it all as you're going.
Great. And you make an excellent point that, I definitely want to reiterate, which is that we cannot be diagnosing anyone through this forum. And the most important thing is to talk to your own doctor. So thank you, Dr. Dewey, for highlighting that. That's super important. We have two questions that are similar and related. So I want to get to that. This will probably be our second to last question, which is
Perfect.
the use of medical marijuana for
Mm,
anxiety. So anxiety you mentioned is a relatively common non-motor symptom.
yeah.
Two people asked about the use of medical marijuana for this
Yeah,
indication.
I think I saw, yeah, a few others that popped
Yeah.
up related to just medical marijuana in general, or THC, and so on and so forth. So not to get too much into the weeds here, because obviously I think this has got quite a loaded back and forth perspective as it pertains to different parties and how they think about medical marijuana for the management of a lot of different things. But I will say this, I was very brief when I talked about management of anxiety, right? And that's because my purpose was not to break down every single avenue that could be useful, for every single patient, because that's always a discussion made between the patient and the provider based off of their comfort levels and what they want to engage with. And I will also make mention that anxiety is a particularly bothersome symptom for many, many patients. When it comes to the specific manifestations of medical marijuana and specifically in Parkinson's disease, I believe, and it's something you probably need to take with a bit of uh, a little bit of caution, simply because certain forms of medical marijuana might have a little bit of a cognitive or cerebral effect beyond just the calming effect. But at the same time, there's actually some additional benefits you could even think about, with some of the kind of increased appetite, maybe helping with a little bit of some of the GI symptoms. But yet again, it can also cause some GI symptoms as it relates to some nausea and so on. So I I believe it's one of those where when you look in the actual literature, it's quite limited with whether or not this truly is beneficial, mostly because there's always a back and forth discussion about how this even should be studied, and is it with medical marijuana, or is it with THC, is it with this, is it CBD, all of these that it's quite politically charged, as we're kind of thinking through how these studies are done ultimately. But ultimately, my challenge is I don't have a perfect answer for this, just because when I look for the data and I look for the answers, it's not robust. But between a discussion between patients and their providers, if this is something that people choose to engage with, that is one of the options that could be done if it's tolerated.
Fantastic. And now for our last question. We are really at the end of our hour, and that is, could you elaborate a little bit on some of these non-motor symptoms that may be related to on-off? We talk about on-off for motor symptoms,
Yeah.
and I think it would be good to maybe end on this as sort of an on-off phenomenon for some of these non-motor symptoms, including
You give
anxiety.
me 2 minutes to answer the most packed question. So on off in general. So I have so many patients, unfortunately, come to me and they're not even sure what we're talking about when I mention on off. Very quickly, when I say on, I'm talking the levodopa or the dopaminergic medication is in your system and working, and the off state is when the medication is not in your system and not working. Okay. So each of these states can actually have their own set of problems. So the off state's probably the easiest one to answer because that's just what patients are like when they don't have the medication at all. So if you just didn't take your levodopa that day, or if you didn't take your, whatever medication is that you're on, it's the typical motor symptoms of Parkinson's disease, including the bradykinesia, the rigidity, and so on. But also sometimes you'll have in the wearing off state some other symptoms. Heightened anxiety is a common one that I'll hear from patients where they just feel almost not at ease. They're agitated because they feel that things are worsening, and they kind of are. They're wearing off their medications. I will sometimes have, as I mentioned earlier, some of that dystonic kind of twisting contortions of either the limbs or particularly the toes or the calves. And I can also have just worsening of some of these other symptoms, even some of the non-motor symptoms. But generally speaking, outside of anxiety, a lot of these non-motor symptoms are not horribly levodopa dependent anyway. So I don't see a ton of that fluctuation from that perspective. From the on state, really the main one, the perfect on state is you're just kind of back to normal, but the most common one tends to be dyskinesias, right? We talked about that. That's another term that gets thrown out a bunch and nobody knows what I'm talking about. That's the excessive movements. Okay. So think of it as almost the polar opposite of Parkinson's disease. This is where you're, instead of moving not enough, you're moving far too much, uncontrollable, sometimes not even noticed by the patient, but noticed by others, where you're just always moving, always moving. That can have its own set of problems, both because it's usually uncomfortable. I've had patients sweating through shirts because of how much they're dyskinetic. As you mentioned, weight loss because you're burning calories through that. That's probably the biggest on state problem that I tend to see. And of course, when you're going from an off to an on, sometimes it doesn't take a whole lot of time before you become dyskinetic, unfortunately, for some of our advanced forms of Parkinson's. So it's one of those we have to be very cautious in determining. And ultimately, step one on this process is quantifying what meds are you taking, when are you taking them, and what is the problem, and when is it occurring in relation to your medication. Because ultimately, that is how you gauge whether or not this is even an on-off phenomena, right? If you're not taking levodopa or a medication that creates an on, it can't be an on-off phenomena, right? And if you are, how I gauge whether I need to go up or down or add a new medication has everything to do with when those symptoms are occurring. I think I
Thank
got through the main points.
you. So on that note, we have to end. We're at the end of our hour. I want to thank you so much for all that fantastic information. And hopefully people who attended learned something today. But if you missed today's program or you want to watch it again, if you join late, you want to share it with somebody, this recording will be available very soon on our YouTube channel, and you will be able to rewatch it. And when you're there on our YouTube channel, please do not forget to subscribe so that you can watch our new broadcasts and be notified when we have new offerings to share with us, to share with you. We have two upcoming webinars that I want to let everyone know about. On August 25th, we are going to be airing a webinar entitled Advocating for Accessible Community Spaces. APDA is going to be joined by the Access Coalition. Going to be an informative discussion about making community spaces more accessible and welcoming for people with Parkinson's and other disabilities. And you can register for that today on our website. And then on September 16th through 17th, we are going to be having APDA's virtual Parkinson's conference, Educate, Empower, Engage. It is a free 2-day program. It is designed specifically for people with Parkinson's, their care partners, family members, and really anyone who wants to learn more about Parkinson's. Our agenda is very full. It has 15 very informative sessions. We have lineups of many expert presenters and panelists, so please join us for that. And you can register for both the accessibility webinar as well as the virtual Parkinson conference on our website at apdaparkinson.org. So stick around for a few final messages. Before I go, I wanted to thank our expert guest as well as all of you for attending, and hope we will see you again very soon on another APDA program. Have a great rest of the day.
Hi, I'm Leslie Chambers, President and CEO of the American Parkinson Disease Association. Thank you so much for joining us today on our program. Every day, APDA is committed to providing helpful programs just like this one, as well as a wide variety of support groups, exercise classes, and educational programs to support the Parkinson's disease community. Whether online or in person, APDA is here for you every step of the way. You can find all of our upcoming virtual events on our website at apdaparkinson.org/events. We keep you posted on our social media channels as well, so make sure you follow us there. You can also connect to local resources and events through our nationwide network of chapters and information and referral centers. Remember, we're just a click or a phone call away. If you've enjoyed today's broadcast, I hope you will consider making a donation to help keep programs like this possible. Every gift, large or small, helps APDA support people living with PD through thoughtful programming, reliable resources, groundbreaking research, and more. Please visit apdaparkinson.org/donate today to support our critical work for those with Parkinson's. We are so grateful for your generosity. Thank you.